I'm Robert Hill, Vice President of Community Impact with the American Heart Association, where our mission is to be a relentless force for a world of longer, healthier lives. In my role at the American Heart Association, I help to build healthier communities, working with leaders, people in business, other community-based organizations to ensure that sustainable change happens and that when I leave, if I ever do, that change is still around, impact is still created around our priority areas, which are nutrition security, emergency cardiac care, and patient care with a specific focus on hypertension. Thank you for being here. Today, I'm going to be sitting down with Dr. Rosendo Collazo from Health Choice Network. Now, before we get started, Dr. Collazo, I have a question for you.
I was just going to say, I want to do what you do.
Thank you. Thank you. Yeah, I do have a lot of fun. Absolutely. Very meaningful work. But a question to start. What is your favorite band?
Oh, that's a funny question considering that I'm a part of a cover band.
Oh.
And so we have hundreds of songs from bands from the 60s all the way through now. But I have to say overall, my favorite of all time is anything Paul McCartney.
Okay, so Wings, Beatles?
The whole thing.
Okay, all right.
And new stuff too, like Gin Blossoms and things like that. That's not that new, but anyways.
Yeah, newer. Great answer. Imagine all the things we can talk about today. I know that's Lennon, but still. Well, why don't you tell us a little bit about Health Choice Network and your role there?
Well, Health Choice Network is a health center controlled network that provides support on many levels to federally qualified health centers and other safety net clinics all over the country, spanning from Hawaii all the way to Puerto Rico. And our role is primarily involved in areas of clinical quality, IT support, finance support, and really just overall support and looking for other areas to expand and improve the quality of care that the federally qualified health centers provide.
Could you tell us what a federally qualified health center is for those of us who may not know?
So a federally qualified health center is a community health center that provides services that meet certain standards that are put forth by Health and Human Services under the health, HRSA and the Bureau of Primary Health Care. And you have to meet these standards on many levels, not just the clinical aspect of it, in order to be a federally qualified health center. And that in turn will commit the federal government and Health and Human Services to provide funding to continue those services in underserved communities.
Oh, I see. So federally qualified health centers are those clinics that are serving those in underserved communities, and you all are the ones that are making sure that those federally qualified health centers can do their job in the most effective way possible by giving them the resources they need.
That's exactly right.
That's wonderful. So through your experience, how does your collaboration with us at the American Heart Association influence best practices in patient care?
Well, I think my experience with American Heart Association goes back even before I was part of the Federally Qualified Health Center movement. As a clinician in the community, an internist for many, many years, I relied on the AHA and its collaboration with other entities that really provided us with the resources to take care of patients. My interest in healthcare has always been cardiovascular medicine and diabetes. And so from the beginning, guidelines associated with AHA, CC guidelines, for example, specifically with hypertension, has always been a very hot topic for me because in my experience, not only anecdotally, but also now with Health Choice Network looking at raw data, is that there's a lot of work to be done to get everybody on the same page and optimize care and outcomes.
I like that. You mentioned data. So let's shift into that, shall we? Talking about numbers and disparities side of healthcare. How does HCN approach that aspect in order to enhance clinical systems for better care for all their patients?
Well, that's a very important question. And the reason is because we serve the medically underserved. What happens is that we have to find unique ways of delivering care that's going to optimize outcomes, right? And so it's important for us at Health Choice Network to use the tools that we have to identify areas where there's care gaps, right? And as such, when we do that, find the ways that we can use the system to improve those outcomes. So, for example, social determinants of health. This is a major topic that is a huge obstacle for people to get the proper amount of care, right? So things like financial insecurity, housing insecurity, food insecurity. These are issues that traditionally in medicine, the doctor may not spend a lot of time or worried about it. Said, here's your prescription, go get your medication. Our role is to bring those obstacles and social determinants of health into the daily management of patients, so that the physicians and the other providers take it into account when they're taking care of these patients, right? And so it's not just a matter of them thinking about it, but it's us putting it forth in the system based on assessments and screeners and things like that, so that the doctor sees that I have to address this, right?
So important. As a public health organization, the American Heart Association finds it so important to address the social determinants of health, and it's great to hear that Health Choice Network is doing so much within that space. When we think about community needs, such as those focused on in terms of the social determinants of health, what are unique challenges that you observe in South Florida? And before you answer, I know recently we hosted a wonderful event together, Heart Equity Symposium on World Heart Day. Why don't we take a look at that while we go into a little bit more about how in South Florida HCN is addressing those community needs?
Okay. So essentially, what I would say about that is that South Florida is the mecca for health disparity, right? And so as a federally qualified health center movement, it is basically the heart and soul of what we do in terms of providing care to patients. It all revolves around identifying access to care obstacles. And so again, social determinants of health plays a big role in identifying specifics where people can then be handed off to provider team members to address those issues and try to resolve those issues. But in the community, especially this community, we have issues of access to care that have not been addressed. And part of that is external factors that influence that, right? So we have the lack of Medicaid expansion, right? So I'm not going to name names, but we've had political leaders who say, you know, if you're an able-bodied, middle-aged man, you should be working, right? Well, that may be true, and I agree with that. However, that person may not work in an environment to provide some healthcare insurance, or that person may not make enough money to be able to afford insurance, but they make too much money to get Medicaid assistance, right? So there's many, many factors. And then on top of that, throw some of the unique factors in South Florida that have to do with language barriers, that have to do, again, with transportation barriers. We are not the mecca of efficient transportation here. So all of these things contribute to lack of access to care. And lack of access to care leads to poor health outcomes. And poor health outcomes leads to increased healthcare utilization and expenditure that can be avoided with a little bit of investment and proactive thinking.
Well, I know that you're speaking a lot of people's language when you talk about increased cost. All of the folks that we work with at the Heart Association, be they healthcare systems, federally qualified health centers, or just members in the community, that's something that always comes up, the unaffordability of our South Florida community. Again, though, I really like that you continue to highlight how much Health Choice Network does to address all of those issues in your daily clinical care. Can you share perhaps some of the initiatives or policies that you've worked on or are working on with the American Heart Association to bring about some of those positive changes?
Well, as you know, we had recently our Heart Equity Symposium, which was an amazing symposium where we brought together so many centers to basically communicate and share experiences regarding certain cardiovascular health issues such as hypertension, right, and hyperlipidemia, and the resultant atherosclerotic coronary vascular disease that comes with that. So one of the things that was inspiring to me as a participant in that initiative was with our excellent quality team was to develop a system-wide tool that's available for 3.3 million patients across 20 centers to utilize the best practices of hypertension management. So we developed a tool in the system that basically takes the provider step by step with clinical decision support along the way, including linkages to things like these are the validated blood pressure cuffs, as you know, that you must use. It's right in their EMR. They can link and go right to it. Additionally, things such as the links to the ACC/AHA 2017-18 guidelines. So those things are right at their fingertips. And furthermore, as they go through the process of making clinical decisions, every step of the way, they get additional decision support tools. So for example, we take away medications out of the primary medication menu that are not adequate medications as best practice, standards of care. So, and then we put in the ones that are. So the first thing they see is the ACC/AHA guidelines say that if a person with stage 2 hypertension should start with potentially single pill combination therapy, as an example. And then the medications they can choose are only those. And they have to willfully and forcefully bypass that to get to some other choice, which is not the best choice. All along the way, the entire tool takes them from beginning to end. And this was really an inspiration from seeing that the way that centers communicated and responded during that symposium, right? And then we were able to use the system to identify what current practices are by using an amazing reporting system within Epic called Slicer Dicer. And we were able to see that the habits of prescribing are 30 years old.
Wow.
The main choices were no longer considered best practices. And so we were able to use that data to convince the centers that this is not the way to continue. We are not achieving best outcomes by using practices that you learned when you were a resident in 1980 or whenever it was.
Perhaps you speak from personal experience there. So, Dr. Collazo, that was a lot of great information, and you're speaking my language, certainly. There's a few things I want to unpack within there to make sure everybody's on the same page. So I heard a lot of mention about the American Academy of Cardiology.
ACC,
American Cardiology.
College of Cardiology.
American College of Cardiology and the American Heart Association. We came out with standards, best practices for blood pressure management.
That's right.
And you also talked about hyperlipidemia, atherosclerosis, high cholesterol areas that we as an organization focus on as well. All of these, it sound like, are built in to the systems that you're helping to employ. And instead of having clinicians just focus on some of those things they learned back in 1980 in medical school, you're giving them the ability to succeed every day by incorporating the newest technology. Is that right?
That's correct. And so, for example, now that you mentioned hyperlipidemia, we have tools that we've put into the system to make readily available the ASCVD risk score for patients so they can see what the risk is and explain to the patient how their risk compares to an average person who has optimal numbers. Additionally, we have educational material that we've put into patient education tools that are in the system that are very important, that the patient either gets through their portal or through printed information that shows excellent graphics that are at the level of health literacy that the patient needs to understand. And we've included in those educational pieces personalized information that says, hey, Robert, your doctor is recommending or has prescribed for you medication for your cholesterol. People with high cholesterol have X amount of increased risk for cardiovascular disease. Your current values are, and we put all this information in there, and the system pulls your information or pulls their information, and that personalized information says, they're talking to me. Wow. This is not just a neutral piece of paper, right? Wow. So we have that, and we're going to continue to do that. We're going to develop the same tools for diabetes. That's a big piece, but we are going to do that. And we do it for a lot of other things. For example, another one that is a big pet project of mine is tobacco cessation. So this is a big project that we need to put there in a proactive way for people to understand that this isn't just check the box and I told you that's not good for you, right? That we need to do more in terms of interventions in giving people nicotine replacement therapy and cognitive behavioral therapy. Those are the things that we, as part of Health Choice Network, with the support of American Heart Association, are able to get done in the system and push that out to millions of patients.
Well, Dr. Collazo, it's evident that Health Choice Network and you care deeply about the patients that you're serving. A lot of wonderful things you're doing tied to tobacco cessation, ASCVD risk calculator, which if that's the 10-year risk of a cardiac event,
correct.
Is that right?
That's correct.
And you also mentioned a little bit about getting the right resources to patients. So a focus on health literacy, even making sure that what you're offering is something that patients can understand. If I may, I want to talk a bit more about the technology that you all lean on. You mentioned an EMR. Can you tell us what that is and how it works?
So an electronic health record, or EHR, EMR, the reason I say EMR because when I'm typing in the system, as you know, in a Word document, if you put EHR, it turns it into her.
Yep.
And I can't stand that. So I always say EMR and I'm just talking about it. I can say EHR, but an electronic health record is the universal way of documenting healthcare nowadays. And it should be more than just a way to document. It should be an assistive tool, almost like an AI tool to help providers communicate with each other, not only within a center, but with other centers that they collaborate in sharing information, which is one of the big areas of effort that we have through EPIC called Care Everywhere. But essentially, the system has many, many tools that assist in that kind of proactive approach and improving health outcomes. So, for example, one of the big things that we spend a lot of time on is optimizing what's called a health maintenance module. And a health maintenance module isn't just a random list of things that a 40-year-old male is due for or a 65-year-old female is due for, but rather a personalized tool that says, Robert has this, this, and this. He has a family history of that, right? His BMI is such and such, and therefore he needs these things, and these have been done, but these have not been done. And so that is basically provider facing on every patient in any visit that they can go in and do that kind of reconciliation. And it's not a matter of seeing things and then ordering things. It's a matter of saying, these are the things you need. And by the way, here are the orders. And they're ready for you to sign. And that's the approach of health maintenance. But we also have what's called UDS dashboards. The UDS stands for Uniform Data Systems. This is the way the federal government talks to, this is the way we as FQHCs can talk to the federal government as to how we're doing on a yearly basis. And there's certain performance measures that need to be met. One of them is hypertension control. Another one is statin therapy for people on with hyperlipidemia. And so that kind of dashboard is readily available to every provider to see what is missing with this patient. So again, a lot of focus on preventive care, a lot of focus on screening and health maintenance, but also a lot of disease management tools, such as what we talked about with statin therapy, for example.
So that UDS, which again stands for
Uniform Data System.
Uniform Data System. It seems as though it's a way that you all employ personalized healthcare for every single patient to make sure what their needs are addressed when they see their clinician.
Yeah, it's another tool. I wouldn't say it's necessarily personalized, but the system is able to drop people into buckets. And so what we're able to do is utilize that information to, let's say, compel our health providers to perform these measures and not ignore them. So if, for example, someone has in the system a certain weight and a certain height and their body mass index is 40, which is considered morbid obesity, it's not just a matter of saying, hey, you need to lose weight. It's a matter of saying, have you made a nutrition referral? Have you made a referral to cognitive behavioral therapy? Because that's really an underutilized method here. And have you provided information on health consequences to this and associated cardiovascular morbidity and mortality? So that's the way we utilize that system.
Sounds like a great resource for federally qualified health centers to have in their day-to-day treatment of their patients.
And it puts them all on the same page, so we can compare apples to apples and see how we're doing compared to the rest of the community.
Now, I know a bit about this, your electronic health record, and how you're trying to create uniformity across the federally qualified health systems that you serve. But could you tell us a little bit about what your EPIC rollout was? And while EPIC does mean fantastic, exceptional, it also has a very specific meaning, right?
Right. I mean, EPIC is considered the standard as far as health record systems across the globe.
Okay.
For many reasons, but EPIC is an amazing tool in terms of providing those kinds of features that many health records don't provide, especially in the area of integrating information from other centers. So imagine if you come to see me and for after an acute condition, and when you arrive to see me, I already know that you were in a hospital in Orlando and you had X, Y, and Z happen to you, and what they did, and what the labs were, and the report of the diagnostic study that was done, and I already have that information, and I'm communicating proactively to you that these are the things that was done, how are you feeling now, instead of saying what happened.
Yeah, and I ate a bad turkey leg at Disney World,
Yes.
So it's
And I read that, by the way.
Yeah. These systems are exceptional. Well, thank you for sharing those insights. It's been very enlightening to learn about the data-driven side, about what Health Choice Network is doing in clinical initiatives. I'd love if you could to speak to maybe a specific scenario where collaboration with the American Heart Association led to a positive outcome, perhaps, and it can be a patient, it can be maybe a specific federally qualified health center, but I'd love to hear about it in terms of how that looked in terms of best practices in a clinical setting.
Well, the issue with that is that we are still in the process of gathering information as to how providers utilize the system in terms of tools that we initiate. So, for example, the hypertension tool that I talked to you about, which is an extensive tool, is really kind of like our first stab at making a universal tool that is hopefully going to improve best practices. And we fully intend, because of our reporting capability, to go back with enough time to see if we've had an impact on how the care is being provided. And as I mentioned, we're going to do the same with tobacco cessation. We're going to do the same with diabetes. And there's so many other efforts that we can do to make that happen. And we have the tools to do it. EPIC is really the way for us to be able to branch out. Look, I was just talking to my colleague about, and I'm going to tie this into cardiovascular health and it's about syphilis.
Okay.
So syphilis, as you may or may not know, is one of those causes of when someone has an aneurysm of the ascending aorta, right above the heart. People don't think about it, but syphilis is a major cause of that, and you have to screen people for syphilis, right? And so there is a cardiovascular consequence to syphilis, and we're talking about articles that have come out showing the amazing explosion of prevalence of syphilis that is happening in this country, right? And so we have a younger population of providers that may not be as experienced in recognizing very subtle physical findings and really have no experience in treating something that was really a non-entity in the past. And so we have now more syphilis cases reported in 2022 than we've had since 1950. That's 74 years, or 72 years. This study was 2022, and a 17% increase versus 2021. So for us to sit back and say, oh, that's terrible, is not good enough, right? And for a physician to say, oh, well, I should be a little more aware of that. No, the answer is we as HCN and a support entity for all of these health centers need to take on the initiative and say, we're going to put this as proactively as a provider-facing issue under health maintenance that says, have you checked this person for syphilis? And do that in such a way that we make an impact, because otherwise this thing is going to be like COVID, that initially was just a few cases and a few more, and then it exponentially exploded. And that's what's going to happen here.
Well, thank you for speaking on the effectiveness of good healthcare, right? Like looking at trends in data and then seeing how those can impact longer, more chronic conditions such as cardiovascular disease. I was not aware about all of that, so you've terrified me sufficiently, and now we know that we just need to be a little bit more better managers of our health. Excuse me. Earlier on, you mentioned a bit about patients' health literacy and ensuring providers are up to date and culturally aware, which I think is a very relevant topic for those of us here in South Florida. What do you hope viewers of our segment today take away from this interview on how best to meet people where they are?
Well, that's a great question, because meeting people where they are is just the beginning, right? Having the tools to ask people about their health literacy in terms of basic questions like, if you're given information from your doctor or from the pharmacist, do you need somebody else to help you interpret and understand that? And that's a very basic way of asking people about health literacy, which sounds like this complicated topic, but the not having health literacy is what leads to complicated topics. So it's important for that tool to be available, and it is part of our screener development for every single patient that is seen. It's in the tools that we develop. Now, again, it's incumbent upon the team, the provider team, to then identify someone who needs further assistance and support in order to achieve whatever health outcomes are specific for that patient.
Sounds like we should all be well informed. I tell that to folks all the time, and I think it applies so well to this case especially. Before we run, is there anything else you would like to talk about or highlight just to bring to the forefront that perhaps we haven't touched upon?
Well, I could say that I really look forward to continued collaboration with the American Heart Association. I look at the AHA as kind of like the hub of a wheel with many spokes. And in some cases, AHA reaches out and brings somebody into that fold. But others have to become aware of that and become part of the fold, because it's not just about resources, it's about support. It's about communication, getting the information out there. So I think in 2024, we're going to do a maternal health symposium. So I'm really looking forward to that.
Wonderful. Well, Dr. Ross Collazo with Health Choice Network, thank you all for tuning in today. Very grateful to have had you join us, and we hope to see you again on our next conversation.